If I can just briefly introduce myself and Combat Medical and tell you a little bit of logistics about today's meeting before we move on to Dr. Guerrero-Ramos's presentation and then the Q&A. So my name's Sarah Bruce White. I've been with Combat Medical since its conception in 2012. So Combat has multiple CE marked devices used in oncology, including the BRS, which delivers HIVEC, or heated chemotherapy. HIVEC is used to maximize patient benefit safely and with good tolerability in non-muscle invasive bladder cancer patients, which I'm sure you all know. So we've had over 800 patients in clinical trials, have conducted over 40,000 treatments, had 5 publications and over 25 abstracts presented over the last 5 years. As many of you will know, HIVEC is used successfully in different patient groups on different protocols, as evidenced by the fact that there were 3 abstracts, including 2 podium presentations selected for this year's AUA, or with different patient cohorts and different treatment pathways. We have in the meeting today, which is great to see, urology professionals and our distributors from many different countries. So just to confirm a few things before we start. In the meeting, all participants now unfortunately muted, just to preserve the quality of the meeting in terms of hearing. But as a host, I can unmute certain participants, and I will do during the question and answer session. Although, to keep it simple, if everyone could please type their questions into the Q&A function across the bottom Zoom taskbar, and then I will address, people can continue to type those questions in as long as we go, and then they'll be addressed later on in the presentation. I will then read out the questions and then unmute people to ensure that the question's been answered and they don't want to do any other follow-up. To preserve bandwidth and meeting quality, if everybody goes to the top right of the screen, they should be able to go for speaker view, which means you'll be able to see Dr. Guerrero-Ramos's presentation and himself while he's speaking. Any problems with bandwidth, obviously turn your videos off. Most people seem to have done that at the moment, and obviously we'll continue to mute. So again, if you wanted to turn your video on when asking a question, you can, but please be mindful that we are recording. That's certainly enough of me speaking, so I'm going to hand over to Dr. Guerrero-Ramos to do his presentation. Thank you very much.
Good evening, everybody. Thank you very much for the invitation. Thank you, everybody, for joining. I'm sorry I have a little spring allergy, so I'm not very well for speaking. And I hope everybody's okay with this COVID issue we have right now in the world. Okay, so my presentation will not be too long. This is what was accepted for AUA in a podium session. These are the preliminary results of our HIVEC HR trial in high-risk non-muscle invasive bladder cancer, comparing chemohyperthermia with HIVEC, with mitomycin C versus BCG. So we know that currently there is no alternative for BCG in high-risk non-muscle invasive bladder tumors apart from cystectomy in certain cases, and also that in the recent years there have been several BCG shortages which have made us look for an alternative for this population of high-risk non-muscle invasive bladder cancer. So our aim was to explore whether residual hyperthermic intravesical chemotherapy with mitomycin C is an alternative to BCG in high-risk non-muscle invasive bladder cancer patients. We designed a pilot trial to explore the effect of this medication in our center, prospective, randomized, and open label with 50 patients to include. As you can see on the right of the screen, we did the TURBT. The postoperative mitomycin instillation was optional. Most of our patients receive it, but sometimes if there's a contraindication, there's no instillation. And those patients which were at high risk, according to the EAU guidelines, with no CIS, were randomized to receive either BCG for 1 year with a SWOG schedule, or chemohyperthermia with HIVEC mitomycin 40 milligrams. We did a 6-weekly installations induction period, followed by a 6-monthly installations maintenance period. The main outcomes for this trial were to explore the 24 months recurrence-free survival the progression rate, cancer-specific survival, the safety of this new alternative, and the quality of life of our patients. So as you can see on the left of the slide, all those patients operated in our center with non-muscle invasive high-risk bladder cancer, that is T1 or high grade or G3, all of those who accomplish all the following conditions, which are TA, G1, G2, who are multiple, more than 3 tumors, and recurrent and bigger than 3 centimeters. We excluded those patients with CIS, those patients, of course, with allergy or hypersensitivity to mitomycin C or adverse reactions to BCG, and those patients with a tumor, urothelial tumor outside the bladder, like upper urinary tract or prostatic urethra. Also, those patients with variant histologies were excluded from the trial, and those patients with urethral stenosis contraindicating the catheterization for the instillations. On the blue table of the left of the screen, you can see the baseline results of our patients. Both groups are comparable. We see they're well balanced, but for one feature, which is the previous recurrence rate of some patients. Those highly recurrent patients with more than one recurrence per year were 16% in the BCG group. We had 4 of these patients in the BCG group, and there were none of these patients in the HIVEC group. That's the biggest difference between the baseline characteristics of both groups, and we'll talk on that later with more results we will present. Regarding the efficacy analysis, we see that in the intention to treat population, there were 6 recurrences in the BCG group and 3 recurrences in the HIVEC group. From these 6 recurrences, 5 of them were progressions to muscle invasive bladder cancer in the BCG group, and from these 3 recurrences in the HIVEC group, 2 of them were progressions to muscle invasive. It's important to say that 3 patients from the HIVEC group at the moment of the analysis of the data had a recurrence diagnosed with a cystoscopy, but had not yet undergone a TURBT, so they have not been considered as recurrence as long as we don't have a pathology for that recurrence in the office. If we look at the per protocol analysis, we consider per protocol those patients who received at least 6 instillations, that is the induction period. So those patients who received at least these 6 instillations, in the BCG group, 5 of them had a recurrence, from which 3 progressions, and none of the patients who received the minimum installation, the 6 installations in the HIVEC group, had a recurrence or a progression. There's a slightly higher median time to recurrence in the HIVEC group, 23 months versus 17 months in the BCG group. Here you can see the Kaplan-Meier curves for both recurrence and progression-free survival. On the left, the recurrence-free survival. On the right, the progression-free survival. Red line stands for HIVEC, blue lines stand for BCG. There's a trend towards, it seems, better efficacy in our trial for both recurrence and progression-free survival with these curves. And as we were saying before, in the baseline characteristics, there was a higher population of highly recurrent patients in the BCG group. So someone may think that this may be responsible for the worst outcomes, higher recurrence and progression rate in the BCG group. So, excuse me, as you can see in the table, on the bottom of the table, from those 4 patients with more than 1 recurrence per year in the BCG group, just 1 of them had a recurrence, which also was a progression, and most of the recurrences and progressions in the BCG group came from the primary tumor group, as in the HIVEC. So we don't believe these 4 patients with more than 1 recurrence per year who were included in the BCG arm are responsible for these worst outcomes in the BCG group. Regarding safety, the red columns are for HIVEC, the blue columns are for BCG. There were more or less the same incidence of adverse events in both groups, although those for HIVEC were milder, more grade 1. You see the same incidence of grade 3 adverse events in both groups. it's really because from those 4 patients in each group, from those 4 patients in HIVEC with a grade 3 adverse event, 3 of them was an allergy to mitomycin that leads you withdraw the treatment, and that's defined as a grade 3 adverse event. There were more voiding symptoms in the HIVEC group that, however, were not permanent, and there were more instillations delayed due to adverse events in the BCG group. Regarding mortality, there were 3 deaths in the HIVEC group and 4 deaths in the BCG group. In the analysis we did, none of them was related to their disease, to their bladder cancer in our patients. So to conclude, our preliminary, and we highlight that this is preliminary results, show that HIVEC with mitomycin appears to be at least not inferior to BCG in high-risk non-muscle invasive bladder patients in terms of recurrence and progression-free survival. Tolerability and safety profile are similar, with milder adverse events and more irritative voiding problems associated with HIVEC, but these promising outcomes and results have to be confirmed after follow-up, complete follow-up of our cohort, and of course in larger trials in the future. Thank you very much for your attention.
Dr. Guerrero-Ramos, thank you very, very much for that. And thank you very much for everyone listening. For anyone that joined a little bit late, the best place to put the questions for the Q&A is in the chat function. So I invite everyone to type questions into that. That's along the bottom bar. And then Dr. Guerrero-Ramos can answer those questions for you. Obviously, this is an opportunity, and I can hopefully people have got some questions, or maybe they would prefer to ask them in person. If there's anybody would like to unmute themselves. We have had a question come up in the chat function asking, how is the availability of BCG in Spain currently?
Okay, so right now in Spain, we're not having real problems with BCG because we don't have so many new patients, as we are not operating due to the COVID situation. But generally, the BCG situation in Spain is that we don't have full availability of BCG. So the Ministry of Health is distributing to all the different regions in Spain, and they warranty us 5 of the 6 induction installations. And then for the maintenance, we have 3 more installations for the maintenance period. And depending on how the situation goes on and moves, we may have more for our patients.
Thank you very much. Thank you. Okay, so there's now some questions coming in. Sorry about that. I'm just going to scroll down because suddenly there was a raft of questions came in. I will come back. So Vikas Agarwal asked whether the device is FDA approved, and I will come back to that in a second because we'll just go through any questions relating to the data. So do you think, there's a question been asked about, do you think HIVEC creates significantly more allergic mitomycin reactions?
Sure, yeah. Compared with normothermic mitomycin, there is more allergy. We studied this in our patients. We have these patients treated with mitomycin and HIVEC, but we have a lot more patients of intermediate risk treated with HIVEC as well. So we saw this, and we studied this, and we saw that our patients with hyperthermia, probably due to a higher penetration through the urothelium, have more incidence of allergy to mitomycin than those patients with normothermic mitomycin.
Okay, perfect. Thank you very much. And we've been asked, could you please repeat why the worst outcome in the BCG group is not because of the 4 patients with high recurrence rates? Does that question you? Okay, yeah. Can you see the slides again? Yes, we can see those. Okay, so can you see also the mouse pointer? Yes. Okay, so you can see, one second, you can see here that
We have 22 patients who were primary tumors and 18 patients who were primary tumors in both treatment arms. And this was the biggest difference in the baseline characteristics. There were 4 patients in the BCG group with a previous highly recurrent rate, and none of these patients existed in the HIVEC group. So we see that most of the recurrences and progressions in the BCG group come from patients with primary or low rate recurrent tumors, and just one of the patients is from the highly recurrent tumors. So that's why we think this imbalance, let's say, between the groups is not responsible for the apparent worse outcomes of BCG.
Okay, and I think that was Franz asked that question. Franz, does that answer that for you? Hopefully, I can't see your video, but please feel free to unmute yourself if you wanted to follow up on that one. If not,
yes.
Oh, yeah.
Thank you very much for the explanation. I really got it now. Thank you.
Okay.
Brilliant. Thank you very much. Thank you. Thank you. So there's a question about any larger trial versus BCG. And again, I don't know if that's a question for Felix or a question for Combat. So what we might do is towards the end, I might invite Edward or Guy to answer a couple of those questions. There's a question coming from Professor Rumiger that says no more BCG in Belgium. And so with mitomycin as well, does that, I'm presuming you have a shortage of both. Do you want to clarify that question, Professor Rumiger? Feel free to unmute yourself. If not,
and also perhaps ask the question of there's a question about the HIVEC schedule in the trial, Felix.
Yeah. If you want, I can answer both regarding the mitomycin shortage as well.
Yeah.
Well, first of all, the easiest one, the schedule we used for high risk, which is this population, was 6 weekly instillations as an induction period, followed by 6 monthly instillations as a maintenance period. That's 12 instillations. And regarding the shortage of mitomycin in Belgium, we have a similar situation in Spain. We've had some shortage after this Japanese factory stopped making mitomycin. But currently, we've been like 2-3 months with certain difficulties for getting mitomycin. But currently, it seems some of it from Turkey, from India is coming. So we have some more mitomycin. But I think this will happen also in the future, as well as with BCG.
Okay, thank you very, very much for that. Another question coming from Antonio Fernandez is, obviously he has difficulty getting mitomycin in his country. And have you any experience with any other chemotherapy drugs?
Well, sorry. We have with intermediate risk patients or patients who were under treatment and have been and have had the issue with mitomycin. We've had to change to some other drug. So we've been using gemcitabine or epirubicin, but this has been like anecdotal uses, and we have not studied the effect of these drugs yet with these patients. But we had to look for something for these patients because they were in the middle of the treatment, and then we found we had no drugs. So yes, we have used several other drugs.
Okay, so that's fabulous because there's been a couple of questions I'm just reading. So somebody's asked specifically any experience with gemcitabine. You just mentioned gemcitabine.
Yeah, we used gemcitabine, we use epirubicin, but just a small number of patients.
Okay, that's perfect. Thank you.
In the mitomycin shortage, there's been a growing number of hospitals that have tried both, as Felix have, gemcitabine and epirubicin when mitomycin wasn't available. and it's only anecdotal information that it's been used safely and effectively in the treatment. Combat is in the process of setting up a safety and tolerability trial, which will be able to confirm these points in a formal setting, so it's not anecdotal, and we hope to be able to collect that data and publish that and present that early next year, which will be looking at both gemcitabine and epirubicin. So we hope to be able to share those results by this time next year with you in terms of safety, tolerability with those specific drugs.
Brilliant, thank you very much for that. Edward, so I'm just scrolling through the questions because there was a lot related to different drug usage. So hopefully that answers that. If anybody would like to follow up on that and wants to unmute themselves to ask, please do. I just don't want to sort of repeat myself there. So another doctor is asking, is explaining that another doctor in India offered 2 patients and didn't find any difference in a weekly schedule. Sorry, I'm just with 40 milligram and 50 mil mitomycin. What could be the answer? Does somebody want to clarify that question?
Yes, please.
From Dr. Reddy, do you want to just reconfirm what you mean with that? Sorry, feel free to unmute yourself.
Yes. The doctor used 2 patients for this HIVEC treatment. The dose is 40 milligrams, 50 ml. Are you audible?
Yeah,
we can hear you. Yes. Thank you. Carry on.
He has used 6 injections each patient. He doesn't find any difference rather than using HIVEC.
Well, I think the question is that this doctor, you mean 2 patients had, one of them had a cold mitomycin, the other had HIVEC. There were no difference. I think, is this the question?
He had 6 patients of pool. He is trying different. 2 patients he is using BCG, and two patients he has used mitomycin cold one, and 2 for HIVEC. And
there were no difference between them.
Yes.
Okay.
Yes.
So I that's like doctor experience, like my experience, anybody's experience. We here now we're talking about a clinical trial, pilot clinical trial. So of course this is not gonna change the daily clinical practice, but this opens the door to a bigger study to confirm these results. Just with 2 patients in each arm, I don't think it's enough to show any difference. And we need larger trials, even with our trial. So I think that may be the answer. I don't know the baseline characteristics of each of the patients and so on.
Okay, if the dose increases, what will be the difference? He will find the difference, like 40 mg he is using, and if he is 80 mg for the patient, what will be the difference?
I don't know which could be the difference. I know the results in our study is a trend towards at least the same efficacy in HIVEC, in high risk, with HIVEC in high risk non-muscle invasive bladder cancer patients. This seems to be better tolerated than BCG, but all this has to be confirmed in a phase 3 trial.
Okay.
Thank you very much. Hopefully that answers the question, and thank you, Dr. Guerrero-Ramos, for answering.
Felix, another good question is what's the reason behind 6 cycles with HIVEC initial treatments?
Yeah, when we designed, there was a colleague who I worked with, which was Felipe Villacampa. He started working on all this, and I started with him, and I want to thank him publicly for starting with this as well. When we started designing this trial, there's no evidence of how to schedule the treatments with HIVEC. This is a new device, so there was no evidence for that. So as BCG has a 6-weekly induction period, we thought that in high-risk patients, maybe we should do the same induction period. and that's why we designed this way. Some other people have asked me in other forums about doing a schedule-like swap with 3 weekly installations at 3, 6, and 12 months. Well, that's for BCG, for the way of, for the mechanism of action of BCG. We don't know, sorry, we don't know if that would really work for HIVEC. Of course, everything we have done can be improved because this is a pilot, very early stage trial. So this is why we decided to start with 6 weekly installations.
And I would add to that as well, and this is also just retrospective data, but from our registry, which we collect patients, which is about 1,000 patients that we've recorded, we see that typically with around 6 treatments is the mean in terms of the average treatment that we get the best results. So it's something that might be, again, just through luck of choosing a number, but that seems to be a number in terms of the different treatment regimes that seems to be yielding the best results. Another question, Felix, that was talking about using, when you use gemcitabine and epirubicin, what protocol do you use when you use those drugs? I know you've only used them in a few patients, but what do you use?
Well, we have 2 kinds of patients in this scenario. One kind of patients are those ones who had already started treatment with mitomycin with HIVEC, and then we had no more mitomycin and we had to switch the drug. So in these patients, we did things quite doctor-based opinion. For example, if a patient had received 4 installations for induction period, what we do in intermediate risk, we completed the 3 monthly ones we do with epirubicin or gemcitabine. But the other kind of patients is that patient who is going to start the treatment with gemcitabine or epirubicin because when he's going to start the treatment, there is no mitomycin. So in these patients, and looking at what we do with cold drugs, we decided to do for epirubicin 4 weekly plus 3 monthly installations, for gemcitabine 6 weekly installations. That is what we do with these drugs at a normothermic temperature.
Thank you very much, Felix. Thank you. Another question from Leishan. Thank you, Leishan. How many stopped BCG due to the side effects, and how many stopped HIVEC due to the side effects?
So in here, I'm sorry. Here you can see on the column, the last one on the right, you can see that 4 patients discontinued HIVEC and 5 patients discontinued BCG due to side effects.
Okay, perfect. Thank you very, very much. There is some questions about other drugs as well, about the effectiveness of epirubicin in treating high risk. Again, you know, I think probably we've given as much information as you're able to give on that. And as Edward explained, we're hoping to assess that. Edward, did you need to add or want to add anything there?
No, we will plan to start a trial so to answer that question and hopefully then provide the information back to the doctors in due course.
Okay, and
there was an interesting question from one of our Indian physicians regarding BCG, and I can give examples of what I see in parts of the world where BCG is still very available and still very effective. In most of the subcontinent and in other places, this is still the case. To the doctor that asked it, BCG is still available and still is the first-line treatment, but the analysis of previous studies will show that up to 40% of your patients will fail BCG. And then if you add into that those who have significant side effects, or in the same sort of geographic areas, those who've had exposure to TB in the past, all of a sudden you get quite a large patient group for whom you have little option other than cystectomy, and this provides a very good procedure and a non-surgical alternative for those guys. I don't know if Felix has any experience around this.
Yeah, there's clearly the efficacy of BCG. There are patients who fail to BCG, who do not complete BCG due to the side effects. And as we know, and for every urologist, we know that after BCG failure, the indication clearly is a cystectomy, but sometimes it's difficult for a patient to accept the cystectomy with this stage of the disease, or even some patients are not really fit for a cystectomy. So there's also this out-of-label use of HIVEC we've had with some patients where we think, and this note has been within a trial, for some of them we think it has had some good effect and have saved them from the cystectomy or from other consequences.
I'm sort of teasing future content. We will have another 2 or 3 of these. I mean, we've had nearly 100 people on this one, which is marvelous. Thank you all. But the next one will be around neoadjuvant use, but we will also have one around use in this very difficult BCG failure group. So I'm sort of, I've got my marketing hat on a little bit, and I'm telling people what's coming in the future.
Sarah, I think you're mute. You're speaking.
No,
sorry about that. Thanks, Guy. Thank you. There is a question from Dr. Wilby. Thank you. Said he'd be interested to hear your thoughts on whether a crossover arm for recurrent patients would be included in any future studies.
Well, I think right now, people at Combat and investigators were open to any future studies and to any design. In fact, Dr. Griffiths in Leicester has been using HIVEC. It's not been like a crossover arm. It's been a sequential treatment using induction period, mixing BCG and HIVEC. I don't remember the exact schedule. So there has been some experience combining both drugs, which could also be a good approach when there is a shortage of the drug. So of course, that's a good idea for the future. And I think everybody will be open to discuss this and to see if it's feasible.
Thank you, Felix. Thank you. And Leishon has actually just asked a question. As with most high-risk non-muscle invasive bladder cancer trials, CIS has been excluded. Do you want to add any comments as to that?
Yeah, we're not sure about, the treatment. CIS is a different entity in these non-muscle invasive bladder cancer high-risk patients. CIS is the direct precursor of muscle invasive disease, and the treatment for CIS is BCG. Is not a T1 high grade where the treatment is TURBT, and then after that we put some BCG in the bladder to try to avoid a recurrence or a progression. So provided that this was a pilot trial, small trial to explore the effect, we thought that including some patients with BCG could make data more confusing, and that's why we decided just papillary high-risk tumors in this trial.
Okay, and another follow-on to that is, was CIS found in any of the recurrences?
I cannot answer that question now. I don't have those data. I'm sorry.
Okay, no problem. And we can always try and get that and follow up after. I will make a note of that to follow up. When some of the questions that we sort of paused on for a second because they weren't specifically related to this data, related to whether the device has FDA approval, whether we're planning on a bigger BCG trial, and somebody was wanting to know more about HIVEC versus cold mitomycin. If there's any more questions for Dr. Guerrero-Ramos or Felix, sorry, would you like to ask them now? If not, what I'm going to do is pass over to Edward to ask him a couple of questions that have come through in the chat. We can always go back to those as well, but just to make sure we don't.
In terms of answering those questions, so the FDA question, we're in the process of defining the pathway, and we're in direct communication with the FDA in terms of what that will be, and we will be a drug device combination. So it adds a little bit of time to the process, and we're also looking at the design for a trial because it will require a specific trial to FDA standards. This is ongoing work, and we've been a little slowed down because of COVID, but that project is fully starting. We hope to have these answers by the end of the year in terms of the pathway and also the trial that we'll have to do. And we're hoping that we'll be able to follow a short trial, so a single arm trial, quite possibly looking at BCG unresponsive, but there are a couple of other options that we're considering. In terms of a BCG trial, we're looking at a high-risk trial and running a larger trial. This is certainly an option for us, and we're considering that. We do have several other trials that we're going to run ahead of this, and we hope to be able to run a head-to-head high-risk trial. But because it's a non-inferiority trial, it will involve a very large numbers. We think we are showing results which are comparable, but we estimate that will be a trial of about 2,000 patients. So we first want to be able to optimize the treatment, and talking about some of the topics that have been raised in terms of actually whether it's 6-weekly treatment, the maintenance schedule, the dosing, which are questions that have come up during the course. We're going to optimize those. Once we've optimized those, then we will run a head-to-head larger trial, but that will be something for the future. And in the meantime, we're going to run some trials where we know that we've been seen to be very effective. Was there any other questions? You're on mute.
Sorry, I muted myself. There was a question regarding the HIVEC trials, where, comparison of heated versus normothermic mitomycin. Do you want to give an update on that, Edward?
We have a number of trials which are presented, this including one which were pilot trials, and also Dr. Anna Platt has presented one on a neoadjunctive single dose before treatment, which is now coming to a conclusion. The two big trials, HIVEC 1 and HIVEC 2, have finished the clinical recruitment. And we were hoping to be able to start getting the data released any time from about now. COVID has delayed that release, and we expect it to be towards now the back end of this year that we hope to have the data, and then the presentation will follow quickly after that. So realistically, it was, like I say, I hope for the second half of this year. It most probably will be the first half of next year before we have access and be able to share that data with you. But hopefully we'll be able to have a direct comparison, hot versus cold, within the next six months, hopefully.
Thank you for that, Edward. So is there any other questions regards the data or anything else that anyone would like to add at this point? We've probably got sort of 10 more minutes, and unless we want to wrap up, and I will tell you about some further meetings that we are planning, and thank everyone. If there is any other questions, I can't, and apologies if I have missed anyone, please unmute yourself now and ask your question. Apologies if I've had, or if you then think of a question afterwards, please feel free to email me. Hopefully everyone has my email following sending the Zoom details later. So again, just email us those. So
I have a question. I was wondering, because you were saying some of the adverse events, or the patients were more allergic to the mitomycin because the mitomycin was heated, the hyperthermic mitomycin. And I was wondering if any of the adverse events that you observed in the combat group could potentially be hyperthermia related.
Well, this is we did not demonstrate the higher allergy rate is due to the hyperthermia. I'm sorry. That's what we suppose after speaking with the allergy doctors in our center and studying that there was more allergies in these patients. So from those 4 grade 3 adverse events in the HIVEC group, 3 of them were due to 3 of them were grade 3 by definition, because in CTCAA the definition is that if you have to take the patient out of the treatment, that's a grade 3. So those are the grade 3 adverse events we had in these patients.
Okay, thank you.
To reference some of our other papers in this area, we published at AUA in 2017 from Shen Tan, and the combination of both groups of HIVEC 1 and HIVEC 2, a safety tolerability paper of 307 patients comparing cold mitomycin with hot mitomycin for safety and tolerability, and the conclusion of that, and they were both from multi-center international, all the patients there, the cohort were from multi-center international prospective trials, and the conclusion of that was that there was no statistical difference. We do tend to get, and again this is anecdotally from people around the world, we tend to get a little bit more lower urinary tract symptoms in the short term, in the sort of first 24, 48 hours. But that's probably due to having the catheter in for an hour rather than having it in for 2 minutes. And there probably is a higher rate of allergy. But again, anecdotally, this is probably because you're getting more mitomycin into the patient. So there is a greater chance of triggering an allergy to it. But neither are significant. And in the published data, it says that there's no significant difference between hot and cold. So that would suggest that the hyperthermia in and of itself doesn't cause any issues. And if you ask the patients when they have it done, unless they have problems with spasm, then it's generally just like a sort of warm feeling as though the cat has fallen asleep on your lap.
Yeah, also, if I can comment on this, we have studied in these patients the impact of the instillations in their quality of life, with both cold chemotherapy, bladder chemotherapy, hyperthermia and BCG. And we found there is no difference in the quality of life with IPSS, PAPL in these patients between HIVEC and cold mitomycin. And there is a slight decrease in their scores in the questionnaires, but they get to the baseline once finished the induction period.
Sorry, thank you very, very much for that. Hopefully that fully answers the question. There is another question just come in about where we can get a recording of this. Everyone that registered for this, I will send a recording out and a survey link just for to see if everyone was sort of happy with things and how we might be able to improve for future. Obviously, this being our first ever virtual clinical meeting. There was another question about are there any other drugs to get better results? But again, I think hopefully Edward answered that when we said we were going to be looking to doing a trial with other drugs. If there's no other specific questions coming through, we'll probably wrap things up. Edward or Guy, is there anything else that you would like to add before I thank everybody and explain when I'm going to be sending all the details?
Thank you very much, everybody, and thank you, Felix.
Yes, thanks a lot.
Yeah.
It's nice to see so many people I know. The names are, as I said in the comments, I've got friends all over the world, none at home, but all over the world. It's lovely to see everybody at this funny time.
Yeah, no, thank you very much, everyone, for joining us. We really, really appreciate you taking the time to join us. And Felix, thank you very, very much for running through that data.
Thanks, everybody. Yeah,
not quite the same as the AUA podium in real life, but we've tried to do what we can. So thank you very, very much. And obviously, if anybody would like any other questions, to ask any other questions, don't hesitate to email. I will send the recording and a survey link. Details to follow, but hopefully 2 weeks today, Friday 5th of June, we should, at the same time, we should have a presentation by Dr. Alexandra Sosa, who's at trial on chemoresection with HIVEC R versus standard treatment in patients with intermediate to high risk non-muscle invasive bladder cancer. It's a comparative prospective randomized control study, preliminary results again, and that was due to be presented also at AUA. Sorry, there's just one final question, Felix, I forgot to answer. Yep. When do you expect, so this is the preliminary trial results, when do you expect to present final trial results? I just realised I missed that question from earlier.
We hope this is the data cut analyzed by the end of, by the beginning of this year, I think. So I think we will have the complete follow-up with the last patient, 24-month follow-up by June, in 1 month, something like that. So we hope that in this year we cross fingers to have this published in a good journal.
Fantastic. Thank you very, very much. And thank you everyone again for joining us this afternoon. Thank you very, very much. Felix, have a lovely evening, a lovely weekend. Stay safe and well, everybody. And
you too, everybody.
Nice to see you all on a Zoom call.